Hello and welcome back for episode 28 of the Noobie Dentist Podcast. I'm your host, Dr. Omid Azami. In this episode, I'm with Dr. Nolan DMD, dentist, dental material scientist, and host of the Biofilm Factor Podcast. We talk about various dental materials that he has been working on and developing and plans on developing in the future. We talk about adhesive dentistry and also talk about his journey from dental school into getting into where he is now. I hope you guys enjoy this episode. And before we move on and start the episode, I just want to talk about a few things that I have been working on. I did an interview with Dr. Ivan Chichon, who is a surgical prosthodontist and runs the Instagram page Implant Ninja. We got talking about implants and my desire to get into implants and start placing implants as an associate. And he told me about a course that he's been working on, which is quite exciting. So his course, the Implant Ninja implant course, is available through online through his website, which I will put in the show notes. And the course is starting in September the 6th. So it's coming out in a couple weeks. And I'm excited to try it out. I hope to be sharing my experiences with you guys as I go through the course. It is meant to be a comprehensive course, implants from A to Z, including homework assignments to make sure you're staying on track. And he has some faculty, some other, surgical prosthodontists, some other surgeons covering components of the course as well. So I'm excited to check it out. I will share my experiences with you guys so you guys can see what it's like as well. And hopefully you check it out as well. If you're interested in implants, I think it's a good way to kind of get going and get started at a reasonable price. So as you can check out his page, Implant Ninja on Instagram for updates. And I will be posting some updates to my story and page as well. And I hope you guys enjoy it. The podcast is available on YouTube, Spotify, the podcast app on iPhone, and Stitcher on Android. So please make sure you check it out. Check out the previous episodes if you haven't heard them already. And just reach out to me on Instagram. I love hearing from you guys. I love hearing feedback. And it just helps me, see what you guys like and don't like so we can grow the podcast even quicker. So without further ado, please enjoy the episode.
Hello, and welcome to the Noobie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Noobie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Azami.
All right, so Ryan, if you don't mind, we'll kind of start off with a bit of an origin story for you.
Sure.
So you can kind of take us back to sort of like why you decided to pursue dentistry in the first place, and sort of like that transition into dental school, and then we'll kind of take things from there.
So I am a bit of a weird story, I guess. I actually wanted to be an engineer, and I have a degree in chemistry. So I was always fascinated by chemistry. I always liked the idea of being able to manipulate the elements and take different things and apply them and make new materials and do different things.
Yeah.
And I actually was a couple of classes short of graduating with a chemical engineering degree. I mean, I've taken more math classes than probably any dentist ever would want to. Chemistry classes.
Zero, so I bet.
Right. No, you're good. Everyone goes and does biology, right?
I did stats or something. Yeah, that's pretty much.
Yeah. So anyways, I'm sitting at home with my parents one day, and basically we're having a conversation, and they go, well, what do you want to do with your life? And I'm like, I don't really know if I want to do engineering. My dad was an engineer. There's a lot of engineers in the family. I go, I don't really know if that is something I could make the most impact with. Mm-hmm. And I say impact, I'm a millennial, man. I love the idea of impact. I'm sorry, I'm get away from that. Yeah. But so I was like, you know what? So we had a conversation, went back and forth. Mom, dad wanted me to be a lawyer. I thought I'd be a great lawyer, whatever. Yeah. I'm like, no, like, what about, and I think my mom said, she was like, what about dentistry? Do you like dentistry? And I go, yeah, I like that I'd be able to use my hands and their science. When I was a kid, I used to build models. I used to build all these Legos. I'd play with the blocks, I'd make everything, right? Mm-hmm. And so like my mom's like, you're really good with your hands. Like, I wonder if that'd be something, because it's also very scientific.
For sure.
And I'm like, oh, absolutely. So then I literally only applied to 3 dental schools. And I actually had really good grades.
Yeah.
And I actually had a great DAT score. but only one called back.
That's not bad. 1 in 3. I think most people would think that.
So I was I think it was at the end of the application period. So there just wasn't as many. I was basically taking a shot at it. I said, you know what, if it doesn't work out, I'll just
try again. Right? Yeah.
So Midwestern calls and says, hey, we want to, have you done for an interview? I go, perfect. So I fly down to Arizona. Mm-hmm. I had a great interview. And then I think it was like 3 or 4 months later, I got a call from the dean, and he's like, hey, I just want you to know, like, be so happy to have you. And I'm like, holy crap, like I got into dental school. Like awesome. What just happened, Yeah. But I love the idea of being able to help people in a scientific setting, but not necessarily just restrict myself to doing things in a lab. I guess if that makes sense.
Yeah.
Sure. But I was probably like one of like 2 or 3 kids that had a chemistry degree going into dental school. So I have a weird perspective of how I view dentistry. Yeah. And you'll probably find that if you listen to my podcast or if you follow me on Instagram, you'll find that I'm always asking weird questions.
Definitely.
That people don't really like. Yeah. They're like, oh, it rubs me the wrong way that you're asking something like that. But at the same time, I don't know what it is. And that's why I'm bugged.
Yeah.
So that's kind of my story of dental school.
Okay. So, you go through dental school, and, it's a common theme like of the podcast that I like to ask guests is like sort of like, what was your vision like when you graduated, and how have things kind of changed or deviated since when you graduated? Or did you know, like, in 4th year when you're kind of wrapping things up and, getting ready for graduation, entering the workforce, that, I want to, pursue some material science stuff and be a clinician at the same time. Just talk me through that like mindset a little bit. Sure. And how things have changed a little bit for you, or if it's been pretty spot on.
The first 2 years of dental school, I always in the back of my head really thought, gosh, there's not a lot of, material science research going on here in dentistry. Yeah. Not to say that there's not great materials, but there's not a lot of research. So I kind of toyed with the idea, but I was in dental school, so busy, I wasn't thinking about it.
Yeah.
So 3rd year rolls around, and, I was in a relationship that didn't work out. So then I ended up having all this time to myself. And I just thought, what I should do? I should find out everything I can about enamel and surface chemistry and everything about teeth.
As you do, yeah.
So
after a breakup.
So I literally spent, it was either StarCraft 2 or it was this.
Yeah.
And I have this little book. I still have it. Okay. Yeah. And it's hundreds and hundreds of pages of just notes, and it's chemical notes, equations, looking at different things, different studies. I would take notes and stuff. So anyways, funny story. Basically, I kind of started talking to some of my professors and some of my colleagues. So, my fellow dental students about some of the things I was doing. And I didn't really get a very positive response. Maybe it was too soon. Maybe people were busy and they just didn't want to hear me out.
Yeah.
I had a couple people that really thought what I was going for was interesting. But for the most part, I was getting pretty discouraged because I'm like, oh, maybe no one really cares about this. Maybe there's nothing to it.
Yeah.
So then it's funny because I think it was like on a day I'd gone to class and I'm like writing my book and I'm not paying attention to what's going on in the lecture. Yeah. And one of my friends sits down and he's like, oh, well, more of an acquaintance at the time, but he sits down and says, what are you doing? What are you doing with that little book? And what are you up to?
Yeah.
And I explained kind of what my ideas were. And he goes, what's holding you back from like continuing this? And I told him, hey, I'm discouraged. Like I talk to people and they don't really see the vision. Yeah. And he goes, how much money do you need to order some stuff to test some of these theories? And I'm like, couple $100. So next day he shows up with $300 cash.
Yeah.
Okay. And I'm doing stuff out of my apartment. All right. Testing stuff, my cat's walking around looking at me like, like, what are you doing? And we just started testing some of this stuff. And, that's kind of how my little materials thing started. We ended up, finding out some really interesting things I can't reveal just yet. Yeah. But basically, we found a couple of really interesting results from some of the stuff I was working on. We started our materials company, and we got a deal with a manufacturer to partner up.
When is this in the timeline? Is this like during dental school still? Or
no, this is skip forward after dental school to about 2015. I applied for a patent application.
Yeah.
To what I had worked on. And again, I had done some testing myself and with my friend.
Yeah.
And then skip over to 2017. I ended up getting a great opportunity to work with a manufacturer, and they were really interested and said, hey, we're willing to put the capital injection in.
Perfect.
And we want you to work full time on some of this stuff. So that's what I've been doing ever since.
Yeah.
So luckily it just kind of worked out for me. And so that's kind of where I'm at.
So you kind of knew from pretty early on in dental school, like this is like your path and this is your skill set that's pretty unique to you, and you're going to kind of pursue that. Is that person who, like your acquaintance at the time, are they still involved in all this? Or?
Yeah, so he's my partner. This is my first partner.
So what have you asked him, like what made him kind of approach you in the the early stage and have that like trust, or like?
That's a good question.
How did that kind of come about?
It's funny because some people, they're just kindred souls, and there's really no way to quantify.
Yeah.
But they just see the vision.
And a
lot of people will not see your vision. And I always tell people, like, don't get discouraged. I had 30, 40 people tell me I was an idiot before someone picked it up and said, dude, this is brilliant. Like, why haven't I heard of this? Like, you're working on something like this. Mm-hmm. And then being willing to, take it to the next level and, bring it to where it needs to be. Someone who can see that vision. There's not a lot of people in the world who can really take it from zero to hero.
Yeah.
And so I needed someone like that to believe in me. And to this day, he's still really, really awesome and helps me with everything. So sometimes you just end up meeting I wouldn't say my other half, but my other half, basically.
Yeah.
In terms of the vision.
That's cool, man. And so, I mean, that's something that I always like think about. I mean, I'm always like, thinking of ideas and how to do things a little bit differently. Like we were talking about a little bit in the pre sort of interview, like we're millennials and we have this like rosy lens. Yeah. We want to make some impact in the world and like have an impact on the profession and kind of do things a little bit differently and for the better.
Sure.
So I'm curious, and it's something that I ask a lot of people as well, is like having vision is one thing. Not many people do, but a lot of people do have visions and have ideas and even great ideas. But like the execution or implementation of these ideas is not always done, right? So a lot of people come short or they quit before they get to that 41st person who believes in them kind of thing.
Right.
Talk to me a little bit about like, once you had that support, a couple $100 is not a big deal. I mean, you probably could have come up with that yourself, but how did you guys like take that, like, living room experiment with the cat walking around to a kind of company, like collaborating with a major manufacturer with some like serious capital behind you? This like that journey is pretty interesting for me. And I know a lot of young people who like listen to this, who have some cool ideas that may be outside the box. There's not many like paved paths like people can follow like this. So if you could talk to me a little bit about that, that'd be awesome.
Sure. So, I mean, I think it all starts with being willing to be able to teach yourself things.
Yeah.
I think everyone expects university to teach them everything and then they're done. You have to literally set aside the time to teach yourself these things because no one's going to do it. I went through hundreds and hundreds and hundreds of articles in the literature and literally just read stuff for like a year. Okay. Yeah. Then I was like, okay, what can I do better? Is there something I can improve upon that's existing? Obviously, there's plenty of room for improvement. We have a profession where we're kind of moving in the right direction in terms of that.
Yeah.
Maybe it wasn't so much that I needed the couple $100. I needed someone to believe in it. And you know what? It's so easy to get discouraged as a young person because you don't have a lot of experience and you maybe haven't had no one's given you the chance to go to bat. So you feel like, oh, maybe it's just not worth it. There's plenty of people who are so brilliant who just, to be honest, get kind of insecure and they say, gosh, my idea is not worth it. I say bullshit. You listen to yourself. Don't let anyone else tell you your idea sucks. Okay. Because until you've actually gone through with it and done the work and seen if it's possible, don't listen to anyone else. I literally was blessed that basically before I was about to throw in the towel that someone came and said,
gave you a chance or believed in you.
Yeah, right. And I think it's more the principle of like, as humans and as millennials and young people, right? You feel like you want other people to believe in it just as much as you do, right?
Yeah.
And so when
huge.
when you hit a wall and you feel like, oh, maybe it's not worth it, it's not because there's a problem with you. It's because there's a problem with other people, and not everyone's going to see your vision, right? Got to bring this book up. Starts with Why by Simon Sinek.
Okay, yeah.
If you're a millennial, you got to see.
He's huge. Yeah,
he's very, very big.
He's become a bit of a cult hero, I think, for millennials. So.
Yes.
Yeah.
So he's right in a lot of ways. I mean, you really have to wake up and ask yourself every day, is this what I want to do, and why do I want to do it? And it's very easy to get discouraged. And I know I'm from a generation that was told, hey, you can do anything, you can be anything. And, maybe the economy wasn't so great when I graduated, and maybe there was a lot of problems, and but I still to this day believe that if you really work hard enough, you can get anything you want. You can do anything you want.
Yeah, for sure.
So that's kind of my take on that. As far as your second part of the question is, how do you achieve that?
Yeah.
Basically read a bunch, teach yourself.
Yeah.
And then apply for intellectual property. Get some intellectual property, and then you'll get an instant deal with any manufacturer you want.
Yeah.
So it all comes down to understanding, spend the time, learn about intellectual property and how you can make something that other people can't. And that's how you secure intellectual property.
Awesome.
Yeah.
And you brought up a good point of, and I think a problem with like social media, and especially like Instagram, where we're both pretty active on there, is you always see like the before and after, and you don't really see like what it takes or what the work that goes into it. So I think a lot of people get discouraged, and I think millennials, I mean, I'm not immune to this. I'm the same way. As like you expect results to come kind of quickly, and when they don't, you get discouraged and you kind of drop your head and you quit, or you stop doing it. But you don't realize you study papers for a year before. It's not like you just kind of woke up one day and your buddy's sitting beside you. He's like, hey man, what are you like working on in that book? And that opportunity arose, right?
Correct.
I think that's definitely a huge sentiment. And I think I even like myself, like I personally have to remind myself, like, if you wake up and you like look at your like download numbers, you're like, oh man, like plateaued. Like, why am I even bothering with this? But like, you keep the vision, keep the long-term view of like where you're trying to get to, and don't let little things like along the way kind of stumble and kind of stop like you from like achieving where you want to get into. That's awesome, man. So the next sort of section I want to get into a little bit with you. Obviously, your main gig is material sciences, and that's what you kind of do on a full-time basis. I know from our previous like discussions, like you do still practice clinically like a little bit as well.
I do.
Yeah. So how I first, how met you is, from like some outstanding like comments, like in some of the stuff that I was posting, like really like in depth and really like thoughtful, and like I actually learned a lot from it. So that was pretty cool.
Good.
So I wanted to touch on like adhesive dentistry and with you a little bit, because I know obviously you have a unique perspective and understanding of the materials, whereas me and majority of people read the manufacturer instructions. They're like, all right, so we'll just rub this for 10 seconds, blow it for 10 seconds. And that's our understanding of it. So the first question I want to ask you is, like, what are like top 3 things that about adhesive dentistry that new grads don't understand or should know?
Sure. Okay, well, I'll start with one. And this is actually kind of interesting. When I graduated, I was doing complete total etch. And basically etching the dentin, etching the enamel, etching anything in sight, right? Like, I need to get the best bond possible.
Yeah.
Okay, you don't have to total etch very much. In fact, these self-bonding systems are basically becoming superior. It won't be long before they trump the total etch systems. I believe we're on generation 7 or 8 now. Probably 7, maybe 8. It's hard to keep up with it all. Yeah. But let's put it this way. Total etch systems are ideal for if you're looking at just enamel, but like recent reports in the literature are coming out basically showing that there's very close follow-up from the self-etch systems. And if you really look at the self-etch systems, it really comes down to a couple of things. They're less likely to attract MMP recruitment, and they're less likely to be broken down over the course. The bond strength over the course of 3 to 5 years is actually superior in some of these self-bonding systems.
Okay.
So you don't want to necessarily, selective etching is ideal. Now, if you're like me, or you were like me when you graduated, and you're so overwhelmed and you're just like, I'm just going to put all the blue stuff in the box, and just like, it's still okay. It's still going to work. Yeah. The thing that you have to be wary of is, and this is a concept that most dentists don't really understand, how long are you spending on rinsing out the etch and drying off the tooth.
That's huge. Yeah.
So two critical components, and I'll tell you why. Phosphoric acid is a strong acid, which means it dissociates 100%. Now, it's H3PO4, which means there's 3 hydronium ions, okay? Yeah. Which means it can potentially release acid 3 times. Most of the time twice, but 3 times. If you do not rinse adequately, even if you've gotten most of the actual debris out, the blue part, whatever, it will linger in those tubules and cause sensitivity. Now, everyone's worried about C factor, and C factor is very important, but if you don't rinse out that acid etch properly, not only are you going to cause sensitivity, but guess what? Now you've set up an acidic environment where bad bacteria love to live. Yeah. So you got to be really wary of that. So I always tell people, be very generous with the water spray that you
How long would you recommend? Like just 20 seconds is adequate?
10 to 15 seconds is adequate, but most people only go for about 2 to 3.
Yeah, you just rinse to see the blue go away, and you're like, okay.
Yeah, exactly. So the other thing, and you really got to think about this, a lot of people over dry their preps.
Yeah.
The second that you've over dried it, those collagen tubules collapse, and your hybrid layer sucks. Okay, you want to talk about debonding? Over drying is a huge problem.
Okay.
So what I recommend to newbies is basically get a micro brush. And the way that you know that you've done enough drying is if you don't see any wetness coming off the micro brush. So don't use airspray to get the majority of it off. Yeah. Only a couple seconds, and then take a micro brush and literally go over the prep until you don't see wetting anymore. And that's the ideal amount of wetness that you need. Okay. You can also use a wetting agent like chlorhexidine and I like using just 0.12% is fine. Some people go as high as 2%. You don't need to. Yeah. But that is also effective as a re-wetting agent, kind of plumps up those collagen tubules before you get the bond in. So you want the real answer is slightly wet. It's kind of like in a recipe where it's like, oh, I need a pinch of salt. What the hell is a pinch? Yeah. Right. But that's
experience. Yeah.
Correct.
So that's what sorry to interrupt for that. So you've etched, you've rinsed, you dry for like a little bit. If you're using the chlorhexidine as a wetting agent, so you just apply that with like a micro brush or a pellet. Do you then do anything like dry a little bit afterwards, or that's it? Like that's ready?
No. Once you've gotten it to the point, and assuming we have a matrix band and it's all nice and fancy, right? Once you've dried it off and you're not seeing like it condensating at the end of that brush, then you've gotten enough wetness off. Okay. And I think that people are so concerned about isolation that they think any kind of moisture is bad. That's true if it's saliva, because saliva is going to get in the way. But basically, like I said, if it's just slightly moist, you're going to get a better bond. And you can read all the reports. I mean, I'm not saying something that's out of line with what the manufacturers are saying, but people get so concerned about isolation, they dry that bad boy out. And then it's like, oh, why did it debond? Why did it break? It's like, okay, but here's the thing. That's not how bonding works, right? Yeah. You know what I'm saying?
Okay. So that's the one. So what else would you recommend, or people don't know that they should know?
I would say this. I would say, as far as bond infiltration goes, and this goes along with the moisture and stuff like that, bond is going to open up those tubules and displace whatever's there. So if there's no water or it's completely dry, it actually can make it more difficult for the bonds to get a good adhesion and a good entry point into those tubules. Yeah. The other thing I would say is maybe this is something that not everyone uses, but I think it's important to note that basically when we're looking at caries detector, right? A lot of people on Instagram are really big on caries detector.
Yeah, the biomimetic guys.
I'm not so much, and I'll tell you why. There's been some studies. I think there's only a 57% repeatability. So in terms of precision, no, it might be accurate. And I don't know about you, but light pink, lighter pink, kind of pink, red, kind of red, that is too little of a distinction for me as a clinician to determine whether or not I should remove or not. Yeah. And let me tell you the second compounding factor that makes that difficult. As you get closer to the pulp, that caries detector is a certain micron size. So tubules actually open up as you get closer to the pulp.
Yeah.
So you might get staining even if there's no decay. And it might stain heavily even though there's no decay.
Yeah.
So the closer you are to the pulp, the less you should use caries detector. And that's when people want to use caries detector.
To make sure.
So I'm going to take a controversial spin on this and just say, if you don't know how to use it and it's not good in your hands, please do not use it. You will pulp out and you are more likely to remove more tooth structure. It's been studied. Biomimetics guys might hate me for saying that.
Yeah.
I'm not saying it's not a good adjunct. I just don't see the reliability. It's been tested many, many times over. So I just, that's kind of where I'm sitting with that.
Okay.
I'm trying to think if there's anything else that I should mention. I think the one thing I should mention about when you're doing, and this is probably a more common thing. I don't know all the secrets, but if you are spreading composite, right?
Yeah.
Everyone knows it's a more ideal to incrementally build something up. We don't all do it. Okay. I've done bulk fill and I've done, incremental.
Yeah.
But here's a situation. If you're looking to get rid of that white line that we all hate and disgust ourselves with, don't use bond after you've placed the composite to spread the composite. Okay. Because really what you're seeing.
I do that. Yeah.
Yeah. No, I do it from time to time too.
Yeah.
Just as guilty. But if you want a perfect, beautiful filling that doesn't have that, that's actually the bond where you're seeing that margin. Okay. So what I recommend to do is just use at the end of your instruments so that you don't get stickiness to the bond, or I should say stickiness to the composite. Use alcohol and just wipe off the instrument, and it actually, believe it or not, works pretty well, and it won't interfere with the bond. So
do you have a little alcohol thing and just dip it in? Between
alcohol swab, and I just put it on my instruments before, and it seems to really work. Now, depending on the situation, I don't always do it, but it seems to, I haven't really had as many white lines, and I really don't like bond at my margins because bond has the least amount of filler. And so I know the idea is to push the composite closer to the margin, but if you're filling that very edge of your margin with bond, it's not going to, it's going to be more likely to chip out, and it's not as high a filler rate. So your adaptation is not as good. The shrinkage rate's higher. That's kind of how I feel about it.
That's pretty cool. And what's your thoughts on desensitizing agents? Is it like snake oil, or is that actually solid?
I don't think it's snake oil. I think that a lot of sensitivity, and maybe you can call me out on this, I think a lot of sensitivity actually comes from over etching. Yeah. I'm not even convinced it's from C factor. Let me tell you something. Everyone's so obsessed with C factor. I've used bulk fill and I've got similar results. I've only had 2 cases in the past 4 years that someone's complained about something like sensitivity afterwards. And that's not my only sensitivity case. What I'm saying is I look at it and it's a very small prep and there's a lot of wall, and I'm like, okay, it's C factor. And the reason why I knew it was C factor is after I prepped it, I replaced it with an amalgam just for an IRM, just for a week, just to see if it was, or a temporary. And then it went away because there was no bonding.
Interesting.
So I know for sure 2 of those cases were C factor. But the bulk fills are getting better. I'm not saying incremental will always be superior. Yeah. But there is a certain time that you have in your chair to get things done. And sometimes it's like, okay, would I rather have isolation and bulk fill, or would I rather spend 30 minutes? That's a really good one.
Yeah. That's a good trade-off to consider.
Yeah. Right. So I think a lot of people are like, oh, I'm going to build it up and spend 35 minutes. And then it's like, okay, this patient has saliva that's coming out the wazoo. Even sometimes rubber dams, that stuff can seep up, especially if it's a big filling, 3-spore surface. Now we're talking, I got to use a Toffelmeyer and then carve this back and then maybe use a Garrison. I mean, it can get real mucky real quick. So,
I think that's the thing with rubber dam too. It gives a false sense of security. You don't realize how much it could be leaking, or you just think oh, it's on, is good. But definitely need to keep an eye on things because
for sure,
not always perfect isolation. Exactly. So next thing I want to, we've already touched on it a little bit, but again, just because you have such a unique sort of perspective on this, from the material side of things and from a clinical side of things, and I know we've had this debate numerous times. Everyone's had on Instagram. So what's if you had to pick, and you open a practice and you have one bonding system protocol in place.
Oh, you're gonna throw this on me.
Yeah. What would you do?
Oh, geez. Do you want my honest answer?
Yeah.
Okay. I would probably do the SC bond universal system. I like that the best. I think prime and bond as two separate steps is still superior. It's more technique sensitive, but it still gives a better result. That's what we're seeing in the literature. Now, there's a lot of great Curare products. There's OptiBond. There's some great 3M products. There's Scotch Bond, etc. Universal. I've used basically everything. I've been around the wheelhouse. I really like OptiBond. I like OptiBond for enamel. But I've used everything. Personally, my favorite is SE Prime and Bond.
Yeah.
I think that's 5th generation, if I remember correctly.
Yeah.
I'm a big fan of 5th generation stuff. I just like it. It makes sense to me. I haven't had any.
You just like the etch with this protocol still, or you just you just do SE?
No, I keep. Look, I try everything, so I don't discriminate. I'm not saying one product is worse than the other or anything like that. I just know it works in my hands. I've read the reports. I know like I said, Curare's got a lot of great products. They're very well studied. 3M's got a lot of great products, very well studied. I just like SE Prime and Bond. That they work the best in my hands, and I just haven't had any post-op sensitivity. I end up with more sensitivity in the one-step systems. So I tend to reserve those for kids and when I need to get in and out. If I don't have time, or if I know they're not going to stay open, or I know I'm not going to get ideal isolation or, perfect results, I'm like, okay, the less time I have to spend in there, I will at least maintain my isolation.
Yeah.
So
what about
that's where I'm at.
is that like a Scotch Bond? Like, what's your thoughts on that? Because doesn't it say for Scotch Bond, like it's even like slightly moisture tolerant and stuff?
I like Scotch Bond. You got to remember at the end of the day, there's a lot of these products, and there's not too many. It's like kind of comparing gasoline to gasoline. It's like, is the 87 better? Is the 89 better? A lot of these companies have very similar formulas, and it's not necessarily different technology so much as minor tweaks. So they're all really going to work as long as you follow the instructions. The real question is what works in your hands and what do you feel like works for you? Yeah. Now, that's a very non-scientific answer. I haven't really found anything that has really said or jumped out to me and said, okay, this is better. I look at the reports. I think the differences are marginal. We're talking 5-10%, more like 5%. Yeah. So statistically, they're very close. I do prefer the self-etching systems over the the total etch systems. But like I said, I just I was taught to use SE in school. I've still kept all the reports. I still think it has the best results in my hands. I like that system the best. But I don't know what you think about this, but as far as bonding goes, I feel like really it comes down to isolation. I feel like you're going to get a better result with your bond and a longer lifespan out of your fillings if you have ideal isolation. Yeah. So I think that's more of a component than necessarily the quote unquote materials themselves. I don't know if that makes sense to you, if I'm just spouting nonsense.
No, I think that I definitely agree with that. And I think that's why amongst like clinicians, you see definitely a trend to rubber dam for restorations or as good as you can. Sometimes not every dentist uses rubber dam and they get great results with like isolite or con rolls, whatever it may be. Right. But I think that is a big factor. Like definitely like moisture can have a big effect on the bond. And we're the same. Like in Australia, I went to dental school down here. We were trained on like SE, like prime and bond. And you get that comfort zone, right? And you kind of trust it and it's worked. It hasn't like failed me yet, like knock on wood. So yeah, I think that's pretty cool. I think I agree with that. I did use Scotch Bond a fair bit though. One of my practices that I worked
it's good.
Back in Canada.
It works just fine.
The selective etch is nice. I like seeing the frosty kind of enamel.
Oh yeah.
Like most of us do, I think so. So next thing I kind of want two kind of things before we move on to like next sort of section is I know you like obviously your podcast is called Biofilm. You work with that kind of realm. So for dentists, I know young dentists we learn it now in school. It's like a thing that we're all endodontic diseases like biofilm, caries is biofilm, periodontal disease biofilm.
It's all biofilm.
What's your sort of like, if you can just give a brief summary of like what we don't understand about it, maybe like in a
Sure.
clinical setting, like how it should impact our like decision making and some treatment options potentially, that'd be awesome.
Absolutely. So think about it like this, right? The biofilm is an opportunistic organism. And I say it's an organism because it's a collective of bacteria. Yeah. If you look at the bacteria on your skin or, maybe, other places, maybe a doorknob, that's not a biofilm. They're individual bacteria that are hanging out. Doesn't mean there can't be a biofilm there, but it's a lot less likely. Mm-hmm. Those bacteria might be able to eliminate them with an alcohol swab or something, just cleaning agent, okay? The bacteria in your mouth that have formed a biofilm, which is basically a collective home where they've come together and they've pooled their resources. It's their community. Yeah. And they are going to take every bit of energy and nutrients they can out of that system. And guess what? We are the host, right? And you almost have to view it like a parasite. It is trying to survive in our mouth. Yeah. I think the thing that a lot of people don't understand is the science is very new. We don't have we have an understanding of, hey, this bacteria does this and this bacteria does that.
Yeah.
There, okay? We have great microbiologists. We haven't studied a lot of the interface between enamel and plaque. And I say this not because we don't know that bacterial shifting doesn't occur, but a lot of people have never heard of this plaque fluid. Have you ever heard of plaque fluid?
No.
Okay, so plaque fluid is really interesting stuff.
Yeah.
For some reason, we kind of lost the research arms that kind of started looking into this in, the early, I think it's 60s, 70s, and 80s, and probably even into the 90s. Mm-hmm. So plaque fluid is the fluid that actually contacts the enamel surface, and it is the interface between plaque and enamel. So it is where all of the interesting and relevant disease processes, ion exchange, and everything that causes decay, periodontal disease, tissue attachment, all this, it is the literal most important fluid that we can diagnose and understand and build our understanding of biofilms from. Yeah. Yet no one is looking at it. So this is how you extract plaque fluid. You take plaque, you spin it, you put it in mineral oil, and you spin it down in a centrifuge at 14,000 RPM for about 15 minutes at -4 degrees C. Ask me how I know. I've done it all the times. And it will give you this weird fluid that you've never seen before. And you're like, what the hell is going on? And it's very interesting. This fluid actually reveals a lot of what's going on because the ions are actually, I don't know if you've heard of this concept, degree of saturation. Does that ring a bell from dental school? Yeah. So degree of saturation is this idea that there is always an equilibrium between your plaque, saliva, and your tooth. So your enamel, your dentin. Yeah. So here's what happens. You have this really interesting fluid that has a lot of biological information in it. Everything from immune factors to calcium levels, phosphate levels, acetate levels, certain ions, sodium, magnesium, zinc, strontium, all sorts of different things that are available. And let me tell you, you might have a patient that has great saliva, but because the biofilm is so opportunistic, if you start looking at their plaque fluid, and so let's say you have a patient, their saliva is pH 7. Oh, doc, I always get decay. I don't know what's going on. Yeah. Then you start looking at their plaque fluid and their bacterial types. Holy crap. There is so many things going wrong in this plaque fluid. The bacterial types are all over the place. They have an opportunistic situation. Saliva cannot remedy everything. And saliva is great, but if you don't have enough of it, or there's not enough mineral content, or you're deficient in this or this or this, or if your diet sucks, you're not going to have a salivary gland that A, secretes enough or secretes high quality stuff. But even if it did, there's still a chance, albeit minor, that some of these bacteria grow, shift, and change the platform that interacts with our teeth and our tissues, and it causes all sorts of damage. I mean, we're talking everything from implant failure, periodontal disease, bad breath, gingivitis, decay, demineralization, enamel substitution. I mean, there's so much going on. So you probably opened a bigger question than you thought you were.
No, now my mind's like, all right, how do I follow this up? So, okay. So, I mean, obviously this is you're coming at this from a material side of things, and I want to kind of bring it back to like applicable clinical. Sure. So how, like, in terms of all this research that's going on, and you or your other people may be working on this plaque fluid. How far are we from some sort of chairside tests to determine if it's good or bad, or if it's something that is going to be an impact on the patient's like oral health?
We're working on it. I think the two major things is we need to be doing what we can do right now, which is pH testing. Mm-hmm. And that's stimulated saliva flow and unstimulated. You can get pH strips. You can pick them up even on Amazon. I'd recommend to do it for your patients who are high risk to at least show them, hey, look at your pH. Yeah. The second thing is there's a great subset of tests from a company, at least in the States, called Oral DNA. They're not the only company, but they have a great subset of tests that are available to show you the kinds of bacteria that you have. Biofilm testing, the problem with it right now is it's expensive. So unless you were to get insurance reimbursements, not everyone's going to be me and buy the $25,000 centrifuge and actually look at it and send it to a lab and test it, or buy the microelectrodes.
It's not practical. Yeah.
No, but it will become practical at a certain point, because here's what's going to start happening. We're going to start testing this stuff, and we're going to start realizing, oh yeah, by the way, in patients that have pancreatic cancer, we notice a 6-fold increase in this type of oral bacteria, and also this type of, ion content in the plaque fluid. And then you start seeing correlations to it, and then boom, now you're going to have the incentive. So there needs to be more research that's done, and I'm probably one of the few people that's actually working on this. But I know, and I'll just answer it for you. Your next question is, how the hell do we apply this stuff, right? How the hell do we apply it?
Yeah.
So what I do is people don't really know what I do. Everyone's like, what do you do, Ryan? I'm like, I don't even know what I do. I'm just kidding. So I study nanomaterials. So I have a background in nanomaterials. I'm a chemist. I really got interested in the properties of nanomaterials because they can get places where other things can't. They have lower resistance rates. You can use less of them, so higher bang for your buck. They have the potential to be made highly biocompatible, unlike some of these things that we're currently using, which would be chlorhexidine gluconate and acetylpyridinium chloride, which actually, even though you think they're biologically friendly, they have a lot of downsides. They're not as biocompatible as you think. In fact, 5.25% bleach is actually more biocompatible than chlorhexidine.
Really?
Yes. Yeah. And so if you actually start looking at the cytotoxicity testing, and again, it's in vitro, but if you actually start looking at how it affects different cell lines, a lot of what we have, they're like biomassacres. They may as well be antibiotics in terms of how much they kill. Mm-hmm. I want something that kills the bad stuff, keeps the good stuff, has high resistance. You don't need a lot of it, and it just is a better delivery platform overall.
Yeah.
So why nanomaterials? Obviously, there's some advantages there. I can't go into all of what I've worked on because we're still in the process of publishing. But here's what I can tell you about some of the nanomaterials that I have. No side effects. They're not going to give you taste changes or stain your teeth. And they don't compete with calcium activity in the mouth. Yeah. Now, let me tell you something about chlorhexidine you probably didn't know. Chlorhexidine is a pH of 3.7. Okay, so it's pretty acidic. Have you heard of this concept called substantivity?
Yeah.
So basically, for those of you listening who don't know what substantivity is basically the attachment of molecules, maybe the adhesion, the adsorption of molecules to enamel surfaces, which can give them a longer lasting effect in the mouth. Well, we're starting to realize that substantivity comes with a cost. And that cost actually interferes with calcium delivery to the tooth and subsequently remineralization processes.
Yeah.
Which is a big problem, because guess why you're prescribing chlorhexidine a lot of the time? High decay risk.
Yeah.
So if we interfere with those processes, so again, this really circles back to there's better options. I'm working on those options. But the real thing that's beautiful about nanomaterials is we now have options where I can start manipulating how your plaque grows, what ion contents are getting into the plaque, and how your biofilm develops over a set time frame.
Yeah.
And I can start controlling it, and then I can test to see if it's controlled instead of guessing at whether or not it's controlled.
That's crazy.
Yeah, so it's nutty stuff. It's nutty stuff.
It's cool though. I mean, I like to zoom out a bit. I was reading like the book like Sapiens and like Homo Deus. Like in the Homo Deus, in that chapter, it does a chapter on like healthcare. He talks about how like in the 21st century we're shifting towards preventative over like treating disease. And this is like obviously like perfectly in line with that.
Correct.
So I mean, this stuff is like, it's like ambitious goals that you're working on, and I'm sure like you're closer to it than many people would think or understand.
We're getting close, my man. We're getting. So
it's going to be like a game changer. I'm interested. Like,
yes,
it'll change everything. Like if you can, it's like quote unquote like cure caries through this or periodontal disease or gingivitis, or obviously in the next level, even if like systemic stuff is linked and that can be controlled a little bit. That's pretty exciting stuff.
Here's the vision. Have someone rinse with something or suck on something instead of taking an antibiotic before they're, scaling and root planing. Yeah. Or, now we're giving this to kids and we're seeing a, 30-40% reduction in caries rate by the time they hit adulthood. So it's all about preventatives. And everyone, I think everyone forgets this, okay? There's this famous quote by G.B. Black in 1896, I believe it was, where he says to a graduating class, one day, and I'll paraphrase because I don't have it in front of me, one day we're no longer going to do restorative endpoint treatment. We're going to do prevention, and that will be a great day. And, this was over 100 years ago, and we're still not there. We're still using the same old. People aren't looking into actually looking at the biofilm and seeing if we can manipulate how it works, because a antibacterial agent is never going to by itself be as good as mechanical plaque removal. Yeah. And we can't replace a toothbrush and floss. But what we can do is we can influence the plaque, and we can influence the types of bacteria that are there that cohabitate this world with us, and select for the better bacteria so that we as mammalian species have the advantage at all times. So, these diseases which bad biofilms cause are less likely to occur. So that's really what I'm looking at. I'm a bit of a mad scientist, I guess. I'm hoping for the best. We're going to continue doing the research, and hopefully we're seeing promising results. It's not systemically reviewed. I don't want to lie to everyone and say, hey, I got the cure. But I'm going to continue studying stuff, and we want to have the best studied stuff out there. So, do
you know if there's like other people doing this?
Not that I know of. I wish there was. I know there's people that are looking at nanomaterials and composites. Yeah. But as far as prevention agents, there's been minimal work done on it, but there's not a lot of work done with actually incorporating the biofilm components. So like actually looking at metrics, people aren't doing that. They might say, oh, great, it killed some bacteria in a jar or a petri dish. Yeah. That's great, but you really need to look further than that. You need to look to see if it corrects the pH. Are we seeing more buffering capacity in the saliva and the plaque fluid? Are we seeing ion changes? Are we seeing bacterial contaminants go down? Are we seeing immune system function changes? Are we seeing a lot of these factors go down? So it's a lot of these things that are associated with disease, whether it be type 2 diabetes or something else, right? Yeah. It all comes down to how your immune system it starts reacting to the kind of bacteria and insults that it has. Mm-hmm. And so you're going to see exaggerated responses in some of these diseases. But they're the perfect case studies to study because you can see how it impacts someone who's already in a disease state, right? Yeah. But anyways, that's basically what we're working on, and it's really cool stuff. And
that's deep. That's incredible. I think that 99% of us don't even think about this stuff on a day-to-day basis, let alone like comprehend like much of it. But I think you just opened a cool window if people are listening, and it's just something to think about for sure and like digest a little bit. And definitely keep an eye out to see where things go. Like it's exciting what you're working on. So it can definitely change the profession. It can change healthcare. This kind of technology going forward So that's pretty cool. We'll see. We got to start looking for other jobs, I think.
Get ready to get nano, guys. Get ready to get nano. It's coming. It's coming. We're coming to dentistry. So
yeah, that's cool. So it's interesting that like it can be incorporated into materials, like restorative materials, and it can be added as an exogenous thing that you rinse or use to control like existing work. So it can help our success rate on our treatment, which is cool too. Exactly. So if you look at it from that perspective, then that's awesome. Perfect. So we talked about it a little bit. I want just from the dental material side, I know it's not exactly what you're doing, but I'm curious to see sort of from your like industry understanding or whatever you're working on, or conversations you've had with other people.
Sure.
Where's like dental materials trending towards in the next like 5 years, 10 years kind of thing? Are we just trying to get better at what we're using, or is there new stuff on the horizon, like replacing like a composite type material, or I have no idea myself. I'm just seeing if you've heard anything different, or what you might know.
I think there is a lot of changes coming up, and I think people are going to be surprised. I don't think that a lot of the technology that we have, it's very hard to make improvements on, because we are at a point, especially with like composite, where we're making marginal improvements on it. Maybe we see 1% less shrinkage here, or 2% less shrinkage there. But I mean, we're pretty capped out on that tech. We're going to see a lot more changes to zirconia-based restorations, I feel like. There's been a lot of people playing around with hybrid materials. So trying to get really good translucency, but also high strength. I do feel like we're going to see some improvements in bonding. Specifically, my group of research, like I said, with nanomaterials, is we're going to start incorporating some of these nanomaterials into bonding agents, into cements, things like that. So we're going to start seeing better long-lasting restorations. I'd like to take the time to point out something that a lot of people may or may not talk about.
Sure.
I mean, maybe you can agree with me, and I'll just let you know, or just tell you this. Are you frustrated with the fact that amalgams last longer than composites?
Oh, for sure.
Right. You're frustrated, right?
Yeah.
But let me ask, we can both agree on this, but I mean, once amalgams fail, they fail catastrophically, whereas composites don't usually. Would that be a fair statement? Usually they fail.
For the remainder of the tooth, you mean? Or like...
So let's say you wrote it out, you see all these crazed lines and fracture lines on this tooth.
Yeah.
And, patient, and most of the time you tell the patient, hey, you should probably crown this or put an onlay on or something, right?
Yeah.
And then they're like, no, it's fine. And then 6 months later they come in and the tooth is like, what happened? Like the buccal wall's gone, the lingual wall's gone. There's a little piece of mesial like still hanging out. Do you know what I'm saying? So
in that sense, yeah.
So amalgams last a long time. But if you actually cut a tooth, I want you to do this for me. Next time you extract a tooth in amalgam, I actually want you to like cut it in half, and I want you to look at the amalgam adaptation, and I want you to compare it to a tooth that's extracted with composite. Mm-hmm. And if you actually zoom in, if you have great loops or you have a microscope, the amalgam adaptation is actually quite poor. Mm-hmm. It actually is not so good. But these restorations last and last and last and last. And I'm talking about the marginal seal. Yeah. And we all know about, amalgam creeping and stuff like that. The reason why amalgams last longer than composites is because there is a chemical interaction that we don't understand so well, but it's something that I study. And if you actually look at composites, their physical adaptation is superior in every shape, point, and form to amalgams. So why is it that an amalgam, which has an opening that when you zoom in on it, looks like a truck could drive through it, and then a composite, which looks like there's not even like a bicycle could get through, but the composite fails sooner at the marginal adaptation? So it really comes down to surface chemistry. Mm-hmm. So it's interesting, and I know these guys in biomimetics, and I tend to think I like to think that I'm in the community of biomimetics. I like to think I'm like that. I might not be after this interview, but
lifetime ban's coming.
They're like, oh, Ryan, really sorry, we're revoking your, amalgam in terms of chemically is more biomimetic than composite. And people are going to just drop their jaws when they hear that from me. Yeah. The reason is if you actually look at the surface charge of enamel, it's negative. So the surface charge of enamel, if there's a phosphate backbone, it's constantly emitting a charge. And that charge is what basically prevents or attracts certain ions and bacteria and all sorts of things. Composite has this huge Achilles heel. It has no charge, zero. It is a net neutral charge.
Yeah.
Whereas amalgam has a fantastic charge because it's got all sorts of metals. Mm-hmm. So the margin is actually protected by an invisible electromagnetic field. And you don't see that, but most bacteria cannot enter or exit through that field without experiencing some sort of damage.
Interesting.
Not to mention, there's release of oxides and metal oxides that end up blocking those tubules. So you might get this old, nasty-looking amalgam, and you open it up, and it's got a dark spot, and it's hard as rock. That will never happen with composite, hardly ever. So just keep that in mind. I mean, I feel like adhesive dentistry needs a couple of those surface chemistry additions, and we can use nanomaterials to edit those composites, which in my opinion are superior in every way with that exception. Change the surface charge, and we're going to start seeing that they last as long as amalgams.
That'd be huge, yeah.
Mm-hmm.
That's pretty cool. So it comes down to that charge, and that's like as simple as, do you think that's like that simple?
I think it really is. I really do. I think that there's a couple of variables to consider. I think pH-based charge and electron density of the enamel or replacement tooth or tooth material, whether it be composites or amalgam or whatever, gold, doesn't matter. You have to mimic not only the shape and form, but also the surface chemistry. And unfortunately, composite still falls pretty weak on the ladder as far as a chemical component. It might have an excellent physical seal, but it suffers from a chemical seal that we're going to see in gold, silver, and even, just to be honest, Emax and zirconia both have a charge. Okay. Whereas composite does not.
Why is that? Why is it just...
So they don't have a fantastic charge, but they're more like glass. So if you look at glass is it's kind of like this weird thing, and I have to actually draw it out for you, but it's got a couple of, looks a little bit like water a little bit, but it's got these oxygen atoms that kind of branch out like this. They kind of look like little sticks coming out. Yeah. And so it's got a weak charge, but glass tends to be partially charged, which is why if you put something in it that is charged, eventually you're going to see a film on the side of a glass beaker. And that's why. Whereas in plastic, you're not necessarily going to see that. So plastic has its advantages. Yeah. But the other thing with the disadvantage of not having a chemical component to kind of projecting this charge into solution, because our mouths are never dry, is that you tend to see more attachment in the rough areas in these microporosities. So it's actually easier for biofilms to attach to and to enter areas which are not well sealed or which don't have charge. So you're relying 100% on the enamel, which you bond to provide that charge density to prevent some of that chemical or seepage or whatever. Yeah. So composites are great. And obviously isolation is a big deal, and obviously seal and roughness are a big deal. Mm-hmm. Sometimes the worst thing that you can do, believe it or not, especially these sub-G restorations, is doing this like windshield wiper effect where you're like, oh, I'm just going to clean up this class 5 with this wonderful carbide burr or something kind of rough. And then it's literally like a safe haven for bacteria. They can just be like, I'm going to colonize there. And, you know, so again, I guess that just finishes my point that, composites, I think where we're going to see improvements is altering the surface chemistry. And I feel like that will be a big deal for longevity.
That's pretty cool. And how far do you think we are from that?
5 to 10 years, I think.
Okay. Interesting. That'd be cool. That's within our career. So we'll have...
I think it will. I think it will happen. The big challenge right now is there's obviously stability issues with getting things into different materials. Yeah. We're working on that. We've had a lot of success modifying different materials to make them more stable, especially in the mouth. The mouth is very harsh conditions. Yeah. The other thing is composites are beautiful. How do we inject some of these quote unquote impurities that might give it a better chemical defense and better charge properties, but don't alter the look? So that's what we're working on right now. I mean, I have a couple projects where we're working on modifying existing material. So I'll keep you posted.
That's awesome. Perfect. So that was pretty, I'm sure a lot of people find that pretty interesting. And it's like a unique perspective for sure. Because it's not, I mean, my chemistry ended in like fourth year, like in first year of undergrad. Like, I was like, all right, that's done. Tick
You're
off
funny.
the prerequisite and then I'll move on. Awesome, man. So obviously you're doing a lot of cool things. You recently came out with your own podcast as well, the Biofilm Factor. Your first episode just came out. I think it was earlier this week or late last week. And I had to listen to it with Stephen Lin, the dental diet. He's Australian as well. It's pretty cool.
Yeah, he's got some good Australians doing podcasts. Apparently.
Yeah. So if you want to just, we'll finish off, just talk about that a little bit. Sort of like what your goals are with the podcast, where you hope it goes. And then definitely I'll put a link in the show notes as well for the listeners to check it out if they haven't heard about it.
Oh, for sure.
It's a great, definitely like very, like I was telling you earlier, it's really well produced and really good content value. So I'm sure people will love it. So if you want to say, talk about that a little bit and where you hope to take the podcast.
Sure.
And then we'll go from there.
So I think that the podcast is more of a pet project. It's something I've always wanted to do. I don't think a lot of people are talking about prevention. And I think there's a really big gap in knowledge and approach to how do we make the next generation of preventative agents. And we need to take an outside look. And we can't just keep saying, oh, here's some fluoride, hope for the best.
Yeah.
We don't understand, even to a large degree, if even some of these reactions that we're using fluoride, or even the pH that we're using the fluoride at, or even the delivery systems are even all that effective. And we have to look at it not from the perspective of a study where we're looking at a population, but as an individual thing. So for some people, that fluoride, maybe that's not as effective as another agent, depending on the kind of bacteria they have or the kind of pH they have. Sometimes you want to look at it from the perspective of the individual instead of looking at a collective result.
Yeah.
And I'm not saying I'm a big fan of fluoride. I'm not an anti-fluoride guy. I think that people who are anti-fluoride are a joke. Don't hate on something that's worked for however many years, right?
Yeah.
So I'm not saying that. I just want more alternatives for people who, maybe that treatment isn't the best option, or maybe there's not as high of an efficacy rate, or maybe we just try and get people on something that, just get something on something that they might use. And so we're looking into that. But the big thing with the podcast too is I want people to understand that the importance of educating individuals on their diet, on how they approach their own health, and what the oral systemic risks are for if you don't take care of your oral health. What can that affect? What kind of organ systems can that affect?
Yeah, that's huge.
What kind of parts of your body is that affecting? Does it affect your lifespan? How you develop? So I'm trying to get a bunch of different specialists, different researchers, doctors, people who have written books, and just talk to them about, hey, like, what can we as individuals do to improve our odds of not getting disease or not spreading disease, or even just controlling our risks for disease. And so I really think it's more of like just trying to get some of that word out there and trying to spread the knowledge. And the end goal would just be for people to just listen. It doesn't have to be your favorite show. I mean, I hope that you learn something. I'd be happy if someone's like, I listen to that and I feel like I got a CE like out of it, like maybe not an hour CE, but like, just like, hey, like, you know what, I feel like I can take that and I can take that to my patient, that I saw last week, and I can tell them, hey, maybe try that xylitol rinse, or maybe you should be looking at the amount of fiber content you have in your diet, because that can affect your gut health, and then as a result, your oral health. I mean, there's so many different links that we talk about, but I think it's all about trying to get dentists to start applying some of these situations to their practice and trying to, honestly, we all want to be better clinicians. Yeah. So start with prevention. I mean, if you start looking at prevention and you really start digging into it, and look, you don't have to get as gimmicky as being super holistic, or, hey, this, coconut oil is going to cure cancer, or I'm never going to get disease again. Yeah. That's not what it is. That's not what it's about. It's not gimmicky. It's like, okay, what can I do to change my odds of getting decay or perio, or even just getting me to a dentist or getting something done. So I'm just trying to get people to really think about their oral health and how that affects their systemic health as well.
That's pretty cool. And I think that's something that as dentists, a lot of us maybe lose sight of or don't focus on the preventive thing, especially with, I mean, maybe a little bit different from like country to country, like with, North America, Canada, and the US having such a like strong hygiene sort of infrastructure in place. They kind of they've kind of assumed that role of like preventative, and we're just drill and fill and fix, right? So
we're endpoint treatment.
Yeah,
endpoint
exactly.
treatment.
So most dentists don't even, and I for myself, like I'm speaking for myself, don't talk to patients about that kind of stuff at all, pretty much.
Right.
Which I hope to change. So I think that's really cool. I think it's going to open a lot of windows for people to like think about these options and see what they can do with it. So is your podcast, do you think general population would benefit from it as well, or is it aimed towards mostly like clinicians and dentists and hygienists and
it's aimed towards both. I would say more probably towards clinicians.
Yeah.
But I have had people message me and say, thank you so much for posting this. I had no idea. It's not like you get to sit there and get nutritional counseling from your dentist, okay?
Yeah.
And maybe we should be talking about whether or not insurance should start reimbursing for that. Because the truth is that, people come to see the dentist more often than their doctor. Yeah. And you really have to take that into account, right? Because if you give them a piece of information that's going to change the outcome of their likelihood for disease, or if you're preventing an issue, maybe they have a high risk for heart disease or atherosclerosis, and you really kind of get them to clean up some of these aspects. And look, I'm not saying it happens in one visit, but you're going to visit your dentist probably more often than any other professional that you see. Mm-hmm. So we need to start incorporating some of these things and thoughts into our practice models instead of just targeting endpoint treatment.
Yeah.
But yeah, man, I think that even as a layperson, you could really benefit from listening. And we're talking about some hot topics, and some of it's going to be controversial, and you might not agree with me on anything. Yeah. I might get some nasty notes on Instagram after this. Yeah. Hey, I don't agree with you. That's fine. I want you to disagree with me because it starts a conversation. Yeah. As long as it stays civil, I am so happy if someone's like, hey, doc, I don't agree with you, and here's why. And then I'll be like, okay, but let's go deeper into the rabbit hole and actually start asking these questions, because then it brings up a conversation that we can all kind of benefit from, in my opinion.
That's awesome.
So it's all about keeping the conversation open, and, I think that's kind of what it's about.
Yeah, I think that's perfect. I think you brought up a good point there, especially with the commenting and positive discussion. I think that's a problem that a lot of dentists, not so much on Instagram, definitely on Facebook. There's so many like pages and groups and stuff that are like so toxic. Like someone posts like a clinical picture, and it's like, what? Like, what's the benefit of, like, who benefits from you just coming here and trolling this guy for like not using a rubber dam for something, instead of like having a informative discussion or constructive feedback or something. So I'm hoping with the millennials, at least, I know that the older generation kind of is pretty set in their ways. The millennials like have a more like collegial environment where we can like support each other a bit better and have like positive feedback and conversation instead of just attacking and pointing fingers and saying I'm better or you're doing it wrong kind of thing. So I think it's a great project. I think a lot of people will get a lot of value from it. So definitely check it out if you're listening to this. The Biofilm Factor. I'll put a link in the show notes as well. So what I'll finish off with, something I've been doing for the past few episodes, is a quick little rapid fire. It's been a pretty dense podcast, so I'll try and lighten it up a little.
No, for sure. Okay. Let's hear it.
All right. So what's your favorite oral bacteria?
P. gingivalis.
Yeah. Okay. Why is that? Just because of the name or what it does?
No, because it causes so many immune issues, and we're starting to realize it kind of sucks.
Okay, nice. What is your favorite clinical procedure to do?
My favorite clinical procedure would probably be on-layer crown.
Okay.
It's fun.
And are you like an Emax guy or?
Emax, second premolar and up.
Yeah.
And depending on the individual, maybe first molar, and then always second molar. I almost always do zirconia.
Yeah. Okay.
Yeah.
What is your favorite dental material?
Favorite dental material? Oh gosh. I'd probably say RMGI. I'm a sucker for RMGI. It's classic and it's old, but I love it. So
it's crazy with the glass ionomers. I mean, in Australia, it's huge. We use it a lot in dental school and like even in private practice. In Canada, like no one uses it. It's interesting. Most offices don't even have it, or don't even like, apart from like an Iona seal, which has like GI in there. But like as a restorative material, even interim or a bit more long term kind of thing, it's not used at all. Which is, I found it quite interesting, the contrast. So what's your top 1 or 2 or 3, depending how many you got. I don't want to put you under the spot here. Things that you would tell yourself on the graduation day now, if you can go back.
Don't beat yourself up too hard.
Yeah.
Keep trying and don't worry about your student loans. It's all going to work out. Still waiting on that third one to pan out.
Very applicable to most people, I think. Awesome. And the last one, I've asked this a few other people as well, is what is your favorite pizza topping?
Oh gosh, man, you're killing me. I'm going to go with bacon. The Canadian in me says Canadian bacon, but I do like, for you Australians and Europeans, it's streaky bacon, but regular Americans, it's just bacon. So bacon, we'll go with
encompassing bacon. Yeah.
That's right.
Awesome. Dr. Ryan Nolan, thank you so much for coming on the podcast. It's a great chat.
Thanks again, man.
Looking forward to your stuff. I'll post the link to your podcast and your Instagram page and everything. So if people have questions, hopefully they can reach out to you on there. And
for sure,
they get a lot of value from interacting and learning from you.
Feel free to message me if you have any questions, if you disagree with me, if you feel like just messaging me because you want to understand something, or if you're looking for more information, or you just want to tell me to have a nice day, that's fine. You can message me. I'm Ryan Nolan DMD. And then I also have my show, which is the Biofilm Factor, which, again, thank you for all the shout outs. I really appreciate it. And hey, man, thanks for having me on the show. And I hope to be back.
Awesome. Yeah, we'll have you once you release your first nanoparticle. Before the IPO goes out, let us know. So
yeah, exactly. You're hilarious.
Make a few dollars to pay off our student loans. Yeah.
All right. Thanks, man.
Awesome. I appreciate it.
Yeah.